HDAC inhibitors, I have a specific affinity to them because I think, we've done a lot of preclinical work. I do think they have a place in the context of myeloma, and somewhere along the way they've sort of been lost and forgotten because we have a lot of other interesting things. There's several different HDAC inhibitors. I've specifically worked with more selective HDAC inhibitors like rosalinostat and citarinostat. These are more HDAC6 specific, but what we have approved is more of a pan-HDAC inhibitor, which is Panobinostat, which has been approved in the context of relapsed refractory myeloma. Now, this is useful in a subset of patients, but the way it was approved, at the doses it was approved, it does have toxicity. And the big toxicities were diarrhea and thrombocytopenia. I do believe that once combined with appropriate partner drugs and with correct dose modification, these drugs can be extremely effective in the relapsed refractory setting. And I do tend to use drugs like Panobinostat when other drugs have failed. The way Pano has been approved is in the context of bortezomib. I will tell you, though, that Pano, when combined with drugs like carfilzomib, works quite well. And in fact, Panobinostat, when combined with the immunomodulatory drugs at appropriate dose reductions, can be extremely effective in patients with relapsed refractory disease who have a high mutational burden like NRAS and KRAS mutations. So, we don't use them a lot because we have a lot of different approaches, but in certain subsets of patients, if appropriately combined and appropriately dose modified, they can actually be quite effective and useful.